Αρχίζουμε με τον κύριο Γιάννου, προεμιλία, και συνεχίζουμε τους υπόλοιπους. Κάθε ένα από αυτούς θα κάνουμε ξεχωριστή εισαγωγή. Οπότε, Χρήστο, έλα, παρακαλώ να σας πω.
Δηλαδή το άλλο.
Δεν δουλεύει εδώ, κάτσε να ανοίξει. Εδώ πατάς και προχωράει.
Ναι. Καλημέρα σας. Good morning and welcome to this mini conference. Now, in the recent news over the last couple of years, you have heard of attacks on hospitals, medical personnel, many who have been killed, taken prisoner, whether in Ukraine, whether in Gaza, whether in Sudan, the Democratic Republic of the Congo, and the number of civilian dead. And you may wonder, because you probably heard that, well, hospitals are supposed to be protected. And people cite the Geneva Conventions, but what exactly do they mean? So I'm going to speak today on the responsibilities and rights of medical personnel during armed conflict. And for this, I have a presentation that I used to do when I was head surgeon of the International Committee of the Red Cross. I am now retired and therefore no longer represent the ICRC. But nonetheless, what I'm about to say to you is still very valid. This is standard International Committee of the Red Cross procedure, standard message. We first of all have to understand the history of this. And και δεν λειτουργεί. Περίμενε. Πού είμαστε? Εδώ. It's not changing. Δεν λειτουργεί. Ευτυχία, πού είσαι? Κάποιος? Και αυτό. Αυτό δεν λειτουργεί εδώ. Έτσι, ναι, εντάξει. Okay. Αυτό, όχι το άλλο. Ναι. So, the idea of international humanitarian law is actually ancient. Almost every society in history had rules about the limits of what could be done during war, armed conflict. In the 19th century, they were standardized and became international treaties. It began with the Battle of Solferino in 1859. There was a Swiss businessman, Henri Dunant, Ericos Dinan, who was looking for a business deal, and he found them there in the middle of a battle. The French against the Habsburg Empire. Thousands of dead and wounded from both sides scattered on the battlefield and abandoned. So he organized the people of the village of Solferino and some local doctors to pick up the wounded, the villagers to pick up the dead. The wounded were taken to the village, kept in the church and other places, and started to organize basic treatment for them. Some of the soldiers wounded were dying, so he had the villagers sit and write a letter which would be sent to their family after their death. All of these things he then wrote into a book which became a bestseller in Europe at the time and created such a movement of consciousness that the Swiss government then brought in, they've given an invitation to the independent states of Europe at the time, all right? Most of the rest of the world, apart from Latin America, were colonies. And they signed the Geneva Conventions. I will talk about it a little bit later. So in his book, he talks about an idea that the wounded and sick on a battlefield shall be collected and cared for. They are not simply cannon fodder. If you send men to war to kill and be killed, you are responsible for their care if they are wounded. At the same time, the idea was those who provide medical care for those wounded or sick should also have a protection. And we will speak later about the protection. And they should not be prevented from exercising their function as doctors and nurses. You cannot stop them from treating the wounded and sick of both sides. Even if you take an enemy, combatant, soldier, prisoner, that prisoner of war also has the right to be treated in the hospital according to his medical needs. So this applies to friend and foe. And you cannot prevent doctors and nurses from treating enemy soldiers according to their medical needs. Now, to designate this action of medical teams, they also wanted a symbol to show that this hospital, this ambulance, these persons in the field are medical teams and therefore should have certain protections. Now, these ideas, as I said, were consecrated in international humanitarian law. This is called international humanitarian law. And in legal terms, humanitarian applies only to war, not to natural catastrophes, although you hear about a humanitarian crisis, etc. No, those are human crises. The humanitarian crisis applies legally only to war. And colloquially, this is also known as the law of war. Now, part of this is called customary law. Customary law is something that has been accepted by just about all societies, all countries, without there being legal treaties. One of the best examples is the white flag. In Europe, at least for centuries, if you showed the white flag, it meant, don't shoot, I want to talk. I want to negotiate. Maybe I will negotiate my surrender. Maybe I will negotiate your surrender. But the white flag meant, do not shoot. I want to speak to you, negotiate. That was not written down anywhere. It became a custom that all societies simply agreed on. During many centuries also in Europe, the idea was you do not attack women and children. Also customary law. Now, this becomes systematized in what is called Hague law, Hague in the Netherlands. And there are treaties of 1899, 1907 about the methods of warfare, the conduct of what you can do or not do with your weapons during war, and what kind of weapons. So, exploding bullets, dum-dum bullets, for example. And then you have Geneva law. Henry Dunant was from Geneva. And the Geneva law protects what are called the victims of armed conflict. Now, Geneva law, the Geneva Conventions, includes additional protocols, 1977 and 2005. The symbols that are recognized the Geneva Conventions and the additional protocol 3 are these three: a red cross, a red crescent, and a red triangle. Or a red crystal, rather, not a triangle, but a crystal. It began with a Red Cross. And during this diplomatic conference in Geneva, which wrote the first Geneva Convention, in honor of Switzerland, the symbol for protection of medical care, they took the Swiss flag, which is a white cross on a red background, and they did the reverse. So you have this red cross on a white background. A number of years later, during the Crimean War, between the Ottoman Empire and Russia, Great Britain, etc., the Sultan, the Ottoman Empire, said, my teams cannot work under a red cross because of the history of the Middle East. During the Crusades, many of the European soldiers involved wore a red cross. And so in many societies of the Middle East, the idea of a red cross refers back to what happened 1,000 years ago, the Crusades. Societies like Greece that have a historical memory of 2,000, 3,000, 4,000 years, they remember these things even 1,000 years ago. And so he said, I'm going to put a red crescent. And that eventually was accepted in the Geneva Conventions. We then come to the problem, modern problem of Israel, who said, for us, cross, crescent, these are too religious and we're Jewish, so we're going to use the red Star of David. For years, the ICRC said, look, maybe historically the cross and crescent have a religious significance, but under international humanitarian law, they are no longer religious symbols. They are humanitarian symbols. And if we start opening the door to people using religious symbols, well, in Nepal and India, and in Sanskrit, the symbol for health is a swastika. And that's thousands of years old. So you can imagine a red swastika, which reminds everybody of the Nazis. So what they did was they created the red crystal and said, within the red crystal, you can put whatever symbol you want. So Israel can put the red Star of David within the red crystal. Countries that have a mixed English and Christian and Muslim population can put both the Red Cross and the Red Crescent, but within the crystal. These are legal technicalities, all right? But those are the three symbols that you're supposed to use. And those symbols are symbols of protection. They are not symbols of medicine or first aid. They are symbols of protection. And therefore, here in Greece, all of these hospitals, private and public, that have red crosses, the use of that red cross is illegal. It is a misuse of the symbol. And there's a law against it, but like many laws in Greece, it is not implemented. Private clinics will use the Red Cross to say we're medical. It's wrong. These symbols are symbols of protection. Who uses them? Well, the very first use, which is a protective use, protection in time of war, are the medical services of armed forces, the military. It is intended for, first of all, the military, not the civilians. Military hospitals, military ambulances, military medics, the military paramedic that goes out into the field together with the soldiers. He wears a Red Cross or a Red Crescent. And it's a symbol of protection. And that paramedic, those military people who use the Red Cross, are allowed to carry a personal weapon. But that personal weapon is for protection of himself and his patients. He must not use the weapon to participate in combat. Your platoon, your group of soldiers is attacking. And you have your gun with you. You go with them, but you don't shoot during the attack. You're there to pick up the wounded. You do not participate in combat. Then we have what is called indicative use. Now, the protective use also, in time of war, the governing authorities can give the right to civilian hospitals to use the Red Cross or the Red Crescent. The governing authorities say, we don't have enough military hospitals. So we will use civilian hospitals, and they say to the civilian hospitals, put up a Red Cross, put up a Red Crescent, so that you also have protection. Then there is something called the indicative use. Now, one of the ideas of Henri Dunant was that in every country, he was talking about Europe, basically, there should be, with every army, a medical service, doctors and nurses. At the time, in the 19th century, the armies of Europe had more veterinarians than they had doctors for humans because of the cavalry. They had horses, they rode the horses into battle. And so they had veterinarians for the horses. So Henri Dunant said we should have an organization of volunteers, volunteer doctors and nurses, a national society of the Red Cross, later Red Crescent, who would go out with the army in time of war. They would not be military, they're civilians, but they would go out in time of war. So you get the National Society of the Red Cross, ο Εθνικός Σύλλογος του Ερυθρού Σταυρού στην Ελλάδα. Ο Ελληνικός Ερυθρός Σταυρός, παράδειγμα. Okay, what does this National Society of Volunteers do when there's no war? Well, they help with what the government wants them to help. In natural disasters, dealing with migrants and refugees, helping with blood transfusion, blood donation. The government gives the limits, and in various countries, there is one program that all 196 national societies of Red Cross and across the world do, and that is first aid. Every national society of the Red Cross has a program of first aid. After that, in Germany, there are 35 hospitals of the German Red Cross that run as public hospitals, not private, as public. In Japan, there are 92 Red Cross hospitals, Japanese Red Cross. And they function as public hospitals, not as private or semi-private hospitals, as was the case here in Greece. So this use of the emblem in peacetime is not protective, it is what we call indicative use. Indication that you are a member of this national society of volunteers that are involved in various activities, social and economic, human activities, all right? And should your country go to war, they are available to go with the armed forces should the government so decide. Who else uses the emblem? Well, the International Committee of the Red Cross. In wartime and peacetime, and the ICRC works only in war. 196 national societies of Red Cross and Red Crescent are grouped into a federation, the International Federation of Red Cross and Red Crescent. And their work primarily, the federation.
No, baby, thank you.
Συγγνώμη,
Να πω.
δεν ακούτε. Ακούτε τώρα. Τώρα. Δεν μ' ακούει. You are screen sharing, εντάξει. Δεν ξέρω τι γίνεται.
Ναι, ωραία, καλά, εδώ σ' ακούω. Οπότε εντάξει, εδώ σου απαντάνε ότι... Ωραία, όλα καλά, προχωράμε.
They're involved primarily in the International Federation in natural disasters. And their work is to coordinate the work of these national Red Cross, Red Crescent societies in case of a natural disaster, and to support national societies in developing their programs. So major earthquake somewhere, the National Society of the country says, we need 10,000 tents and 50,000 blankets. They send a message to Geneva. The Federation sends a message to various societies. The German Red Cross says, we have 5,000 tents. And the British Red Cross says, we have another 5,000. The French Red Cross says, we also have 5,000. Federation says, keep your 5,000. We have the 10. Keep the 5. Wait for the next earthquake. But do you have blankets? So they coordinate this international help to the national society there where there is a national society, a national catastrophe. So the ICRC uses the emblem. The Federation uses both cross and crescent. And in time of war, for the ICRC, that Red Cross is protective. The ICRC will also buy all of the hospitals in the countries at war. And they will take the coordinates and they will give the coordinates to both sides, saying, these are the hospitals that have protection These are their coordinates. You are not supposed to shoot and bomb them. Now, the Geneva Conventions also include protection for other people. The protected persons in time of war include those who are not taking part in hostilities. Civilians, in other words. The legal language is no active participation. Soldiers, combatants who have laid down their arms, surrendered. They're not fighting anymore. An enemy soldier, you take him prisoner. You don't shoot at him. They're no longer participating. The same for those soldiers who are called hors de combat, out of battle, due to sickness, wounds. They have been detained, therefore they are prisoners of war, POW, or for any other cause. So I'm surrendered, or I'm sick, I'm wounded, and I'm no longer participating in combat. I have been taken a prisoner of war. All of these people have what is called protection, legal protection. They should not be mistreated. And it's very interesting that in all, there are 4 Geneva Conventions, all 4 have a common Article 3. Κλείστε το μικρόφωνο σας, παρακαλώ. And that common Article 3 is the wounded and sick shall be collected and cared for. So evacuation from the battlefield, all right, cared for in medical facilities. That article exists in all 4. It's called Common Article 3. And it is the basic idea of the Geneva Conventions. The first Geneva Convention is called the Convention for the sick and wounded of soldiers of armed forces in the field. All 4 Geneva Conventions have this common article. If those people are protected, who else is protected? Well, the people who provide medical care. So the doctor, the nurse get protection because they are treating people who are protected, the wounded and sick, civilians or military. It's not because you treat a combatant or a soldier that you have committed a crime. On the contrary, you're supposed to treat them. They're not supposed to be cannon fodder. And because you treat a soldier or combatant does not mean that you lose your protection. Of course, not everybody follows the rules. This is the reality. We know it. And we hear about examples of it every day. Attacks on hospitals, attacks on ambulances. So this is an ICRC car from 30 years ago. Same thing happens sometimes today. And this is the operating theater of a hospital in ex-Yugoslavia. The war 1992-93. But you see the same thing today. So it happens, it's repeated, and it's in the news. What is not in the news is the number of hospitals and ambulances that are not attacked. It's not the news if people respect the Geneva Conventions. And believe me, in 35 years of working in the field and in Geneva, I've seen many, many situations, many wars where hospitals, ambulances were not attacked. They were protected. But that is not in the news. Protection for the medical mission implies the personnel, of course, the medical personnel, the units and facilities, so first aid posts, hospitals, ambulances, helicopters. Your helicopter with the Red Cross carrying the wounded should not have a heavy machine gun and shooting at the same time. In that case, it loses its protection. And of course, the wounded and sick. So medical personnel, people signed exclusively for medical purposes or for the administration of medical units. It's not just doctors and nurses. The administrators of a hospital also, because without the administrators, the hospital does not function. What are the duties of medical personnel in time of war? Benefit from this protection. First of all, you should be aware of your duties. You should know international humanitarian law. Now, the Geneva Conventions are not long. The first Geneva Convention involves armies. The second, navies and shipwrecked sailors. So if you're working on land, you're not concerned with Convention number 2. Convention number 3 is for prisoners of war. And Convention number 4 is for civilians. And these were negotiated in 1949, right after the Second World War, and because of all of the horrors that we saw during the Second World War. They're very short, and a lot of it is repetitive from one convention to another. So you can actually read the Geneva Conventions in about 20, 25 minutes. That's it. So first of all, to benefit from the protection, read them, be aware of your duties. What are you responsible for? You must not be involved in acts of hostility or military activity. There must not be a tank in front of your hospital shooting. There must not be an artillery police, all right? The hospital should not be. The presence of soldiers who are not fighting, not shooting, does not mean that you lose your protection. Be actively involved in hostilities. Why are they in the hospital? Well, they carried a wounded person. They're seeing wounded friends, family, but they're not shooting from the hospital. The hospital is not participating in combat. And you must be identified. You must be wearing the emblem. And you put the emblem on the hospital, all right? If you go out of the hospital, like ambulance drivers in Gaza or the Palestine Red Crescent ambulances, and the paramedics have a Red Crescent. In Ukraine, they have a Red Cross. The duties. Well, what are the duties of medical personnel? in time of war. Respect medical ethics, the ontologia. Begins with the Hippocratic Oath, do no harm. And the modern version of the Hippocratic Oath, all right? Done by the International Medical Federation of Medical Society. Johannesburg Declaration, which is basically medical ethics that we apply for our patients in peacetime and in war. And part of that is sick, wounded, you treat according to their needs without discrimination of any sort. So I'm in my hospital, and from the prison, they bring me a murderer and a rapist. Tried, found guilty, and is in prison. And he now has appendicitis. What is my job? What is my duty and responsibility? Treat the appendicitis. He's a murderer and rapist, but he's also a human being. And I am not a judge, I'm a doctor. There is a system called the legal system of police and courts and lawyers and jails that take care of the criminal. I take care of the human being. And so I treat that murderer and rapist according to his medical needs, no discrimination. So I don't need to talk about discrimination on the basis of sex, age, religion, ethnic origin, political opinion. It applies for everything. Your duty is to the human being. And you have a duty with your system to be actively involved in the evacuation, the transport of the wounded and sick, to look for them, not to abandon them. To the extent possible, you try to find them. And then apart from those duties, you have rights. And your rights include that you should be respected and protected. You should not be attacked. You should not be shot. You should, all right? You should not be taken prisoner. You should not be punished as you are taking care of the wounded and sick. And that includes military combatants. As a doctor, my job, my responsibility is to take care of the wounded and sick, civilian and military. And I should not be punished for doing that. Even if some of those combatants are called terrorists. That does not make me a terrorist. It means I'm a doctor. Personally, I've been taken prisoner of war. During the Israeli invasion of Lebanon in 1982, I was director of a Palestine Red Crescent hospital, and I, along with all of the male staff, doctors, nurses, X-ray technicians, the administrators, we were all taken prisoner. There was another Palestine Red Crescent hospital in another city a little further south, and they were not taken prisoner. There was an ICRC delegate there who stopped and said, these people are under my protection. And the Israeli army did not take them prisoner. We were taken prisoner, which means we were prevented from continuing to take care of our patients. You can only do that if you, the military force, then take the responsibility for treating those patients. After a couple of weeks, I was released. A year later, I was responsible for the medical treatment of an Israeli prisoner of war who was being held by the PLO, the Palestine Liberation Organization. So I had to go under bombs to reach my patient who was an enemy, because my responsibility was to my patient. And my first responsibility is always to my patient, friend or foe. I shall not be punished because I have treated persons, even what are called terrorists or criminals, the murderer or rapist, because I have followed medical ethics. I should be punished if I have performed acts that do not follow medical ethics. Now, this comes out of World War II. A very famous Imperial Japanese military medical unit, 821, that did horrendous experiments on people. The Nazi doctor, Mengele, also horrendous experiments on people, Jews. This is not permitted. This is because you are breaking medical ethics. So you should not be compelled. The commanding officer does not have the right to come in and tell you, do this and this to this patient as a punishment. And you refuse. You should not be punished because you are refusing to break medical ethics, to participate in torture or the mistreatment of prisoners. And there's a very famous case in the United States of two psychologists or medical personnel who broke the rule of medical ethics and participated in establishing the program of interrogation of terrorists, many of whom ended up in Guantanamo prison, many of whom were found not to be terrorists at all. They were picked up like this for various other reasons, but they had been tortured in effect with the help of these two psychologists. And the American Association of Psychologists has condemned them, thrown them out of the association. You are not allowed to participate in acts of torture or mistreatment of prisoners. That includes prisoners who are on, for instance, a hunger strike. Now, as I said before, not all of these rules are followed, unfortunately. And we've seen many cases in the last few months, hospitals being bombed. Oh, it's a control and command center. Well, does that mean that every hospital is a control and command center because you've bombed every hospital? That can't be true. Command and control center, there's usually one, not 10, 20. The presence of armed men. The wounded is sick, they're supposed to go to a hospital. They are not cannon fodder. And I'll explain to you what happens in the chaos and confusion of war. You get a rush of wounded to the hospital, to the emergency room. Amongst them, you have some combatants. They're carrying their guns. They leave their wounded comrade, and then they leave the hospital. And very often they forget the gun behind. The gun is picked up, it's put in a corner. And it's supposed to be given to the combatants, okay? But very often, again, there's confusion, and the same combatants do not come back. And then you have 4, 5, 6 guns sitting in the corner. That does not mean that the hospital has lost its protection. It means that there's been chaos. The presence of those guns not being used in active combat does not mean that the hospital has lost its protection. And that is the reality of war. And every army that has been at war knows that that is the truth. They know it, no matter what the propagandists say. Because they are soldiers at war. They know the chaos that occurs in hospitals, all hospitals. The government propagandists will say the opposite. Humanitarian law says the opposite. The presence of those guns under those circumstances does not mean that you lose your protection. Only if you use those guns actively in an offensive way. So this is a very quick overview of international humanitarian law, and you will find more details in various documents of the International Committee of the Red Cross on the website, and particularly international humanitarian law for medical personnel. There's a whole chapter in the War Surgery book published by ICRC, Volume 1. And I thank you. Questions? Erotices?
The different
Symbols?
symbols is related to religion.
Originally, centuries ago, yes. I mean, even the Greek flag with the cross in the corner, that's a Christian cross. It's the crescent. Look at the flag. Wait a minute. Look at the flag of Turkey, Tunisia, Algeria. Okay, there is a crescent. All right. Originally, these are religious symbols. The international meeting now before the United Nations, 1949. No, the crystal. The crystal was used so that to allow the Israel to use the red Star of David. They put it inside the crystal. So it's the crystal that gives protection. And then inside that crystal, you can put the red Star of David, you can put a cross and crescent, you can put a picture of your mother. Doesn't matter. It's the crystal, all right, that provides protection legally. Now, as I say, originally cross and crescent were religious symbols. Before the United Nations, the major diplomatic conference was the International Conference of the Red Cross and Red Crescent, which also takes place still every 4 years. And all the signatories of the Geneva Conventions, which means every single country in the world, participate along with their national society. In 1929, that international conference proclaimed that the cross and crescent were humanitarian symbols and not religious. They would have no religious signification. So that's the legal, all right, in the minds of most people. Now, very interesting. In 1863, when they were negotiating that first Geneva Convention, and with Henri Dunant, Eric Dinant, there were another 4 Geneva. And one was a surgeon, Louis Appia, in the committee, all right, the original committee. And he said, for a symbol of protection, I would prefer a simple white flag. No cross. The diplomats participating didn't listen to him, which has created enormous problems afterwards because of the cross and the crescent and everything else. If they had listened to this surgeon, who was not a lawyer, not a diplomat, if they had listened to him, he would have avoided a lot of problems that occurred because of the use of these symbols. Any questions? Σε ευχαριστώ.
Και ο επόμενος ομιλητής, Μάουρο Περέιρα, είναι Πορτογάλος, αναισθησιολόγος. Ήρθε στην Ελλάδα σε μια προσπάθεια να οργανώσουμε εκπαιδευτικά μαθήματα που έχουν σχέση με το τραύμα από την είσοδο στο νοσοκομείο μέχρι και την τελική του έκβαση. Και θα κάνει την επόμενη ομιλία. Μάουρο Περέιρα, αναισθησιολόγος από την Πορτογαλία. Και τώρα πρέπει να... Οκ. Πρέπει να κάνω τώρα στο share.
Only to bring a little bit of what is damage control mainly in the ICU phase of the trauma care, and always to put something about teamwork, because it's something that I like. I think it's important, and it's very different between the reality of the trauma care that every local has. Okay, so it's a little bit of our way and our problems in Portugal. I pass. So this is my hospital in Braga. I'm an anesthesiologist and intensive care doctor with a likelihood about trauma. Okay, that's probably the reason why I'm here. So the objectives is to talk a little bit what is the concept of damage control for those who are not aware of it, because I don't know all the audience. Okay, what are the principles, what we should do in the ICU phase of care, and talk a little bit about how can we use teamwork after the initial resuscitation based in your own reality. So quickly, damage control is the restoration of physiology. That is our objective using damage control interventions. So it's the physiology over anatomy until it's needed. But it's also always have in mind that it's not for all patients, it's only for the patients that need a damage control. The use of damage control in the incorrect patient may be harmful for the patient. It is a stage process. It is important to decide early when you have to do a damage control and not late. And the definitive treatments only takes place when we have corrected the physiology. So the concept began with the militaries. Okay, this is an example of a flyer from the World War II, where they started the concept of the damage control. It was not this one the first. Okay, this is just one, and it was in the news. And they say that good damage control in all spheres, coupled with courage and determination, save the ship. So it's a little bit what we do in damage control. We correct the physiology, that we call that the damage control resuscitation. That for me, it is the whole process. Everything is damage control. Control the bleeding, reverse anticoagulants. Everything is part of the resuscitation. In the interventional side, it's stop the bleeding and contamination. That is damage control surgery, or in some realities, endovascular interventions. Then the phase of normalization of physiology, because when we stop the bleeding, the patient doesn't be good right there. And later that we have the definitive treatment. So it is analogous to what they do. They want the ship to float, move, and if possible, they want him to keep fighting until they get to the harbor. So it's a little bit what we do with the identify the need, stop the bleeding contamination, and restore the physiology in the ICU. So just so you to know what is the objectives in the phase in the damage control surgery. There are a lot of surgeons here. Okay, I'm not a surgeon. So the objectives is simply control bleeding, control contamination, and try to preserve the function until you can do the definitive treatment. Though that can be with simple steps that surgeons train and who likes damage control do it effectively and fast. Okay, you cannot take too long because our patient is getting worse. They are not capable of how to say in English, of a long surgery. They need to restore the physiology. So it is a stage process. This is the steps, the selection of the patient, the resuscitative intervention, the restoration of physiology, and the definitive surgery in a simple way. And you also have to keep in mind that the patients can go back and forwards if they need, if the physiology mandates what they need. And what about the part of damage control resuscitation? I used to say that is also very simple. We must be simple to be able to get a good outcome. We must have simple objectives. The surgical part has simple objectives, so the resuscitation part, that is part of everything, must be also very simple. Permissive hypotension, hemostatic resuscitation with the minimize of crystalloids. I like always to say this because we keep seeing that people are not doing this. Early hemorrhage control, correct the coagulopathy, and correct metabolic derangements. Why I say it's simple? Because we only want to address three things. We want to reverse or avoid the acidosis, hypothermia, and coagulopathy. We want to treat the little triad, and we can now add it the calcium and call it the little diamond because we know the importance of the calcium. And for this speech itself, we can do a little bit of the distinction about what is before ICU admission and what is after ICU admission. The before, it was what I talked before, and after ICU, we have all the steps pre-ICU, but we also have to keep in mind there are some things that we must do. For example, people can get to the ICU because they are so physiology deranged that they may need to complete, for example, the secondary survey because there was no time for doing it in the initial. So the patient went straight to the OR. So someone has to look out if we missed anything. And even the tertiary survey, I don't know if you are aware of the concept. In some realities, people don't like it, okay. In other realities, it's a national standard of care. And also, we have to start to manage specific issues of the individual situation. Of course, this is different if it's in the first 24 hours, after 3 days, after a week. That's why that in the DSTC courses and manual, we have divided these ICU phases in 4. Okay, it may exist other ways, but this is the way that we teach it in the DSTC. That is the resuscitative phase, early supportive phase, prolonged supportive phase, and the recovery phase. And they have more or less timings. The timings are not strict, are not closed, okay? We don't pass from one to the other because it's past 24 hours. No, it's like an objective time. We want to be able to get these goals. So in the first 24 hours, we call it the resuscitative phase, and the objectives are similar to the beginning, the restoration of the cellular oxygenation and the perfusion. So we want to save the cell, so we are able to save the whole body, okay? And always keep in mind the last sentence that in all moments, the team must be alert for the need of an emergent re-intervention. Okay, when we are not getting to the point of improve the patient, we may need to go back to resuscitative intervention. And the objectives of this phase are the same as the damage control resuscitation, is reverts, in this case, the little diamond. So we must stop it in every way that we can do it. The objectives, how do we know that we are being good in our treatment? In modern ICU practice, we have a lot of machines, a lot of goals that we want to achieve. But there is no standard endpoint that we can say that is the best, because it's different. Your Greek ICUs, my Portuguese ICUs, US ICUs, depends a lot of your organization, a lot of your available equipment. Okay, I don't have everything in my ICU that I would like to have, and someone has a lot. So the bottom message is that the most important is to see a curve like this. So the derangement of the patients in the time frame must be getting better. That is the most important. There is no one single parameter that you can say that the patient is improving. It's the mixed of a lot of parameters, and they have to, a long time, they need to getting better, okay? That's the way I know the patient is getting better. And always search for the occult, life-threatening and limb-threatening injuries, because they exist. Sometimes people do the initial surgery, the initial resuscitations, and some hours later, someone find out that was a life-threatening injury that was not find out. I don't know if ever happened to one of you. It happens to me already. Okay, so that is always on the search. And then we have the early supportive phase, and normally between the first and the third day, that we want to contour a continuing restore physiology. Normally, in case that you choose a damage control surgery, it's the time frame where happens the second look, for example, for a damage control laparotomy, but it's also not fixed, okay? It is in the right time that should be done. And in this moment, we know that there are two things that normally start to arise, that are the post-traumatic respiratory failure and problems with the intracranial pressure, okay? That is the two principal things that kill the patients in this phase when they have not died because of hemorrhage at the beginning. And also in this phase, at 24 hours, we should have completed the tertiary survey, and always keep in mind assessment for the need of an emergent reintervention. That is always present in our practice. The problems that arise in these days, so respiratory insufficiency, intracranial hypertension, we start to see the systemic inflammatory response. Probably we start to see it earlier, but normally in this phase, we are going to see it, and we start to see organ failure. That is the moment that we normally start to have to do other supports than the initial one. The priorities are the same as before: the control of intracranial hypertension, the institution of the nutritional supports, very important, the prophylaxis of venous thromboembolism. I don't know what is your practice. In my reality, we started very late for what is in the literature, for what is the science. We started very late for fear of the practitioners only, not for fear of the evidence, because the evidence is very clear. And also remind that you have to withdraw or replace all the trauma resuscitation lines or devices that normally have not been put in good aesthetic conditions. So this is the time you should remind to replace it for more secure ones. Then we enter the prolonged supportive phase after the 3 days, 4 days, 5 days. I know that depends on the patient, depends on the physiology, where we want to prevent or treat the organ system failure, isolate or eliminate inflammatory infection sites, because in this moment we are going to start to have infections, complications for sure. And if you are in a very good working environment, you also can start physiotherapy. You can start rehabilitation with a patient under sedation if there is no problem for the patient. How soon you begin, less complications afterward, less ICU syndromes afterward, okay? So during all this time, we put together these 3 phases and we put together the surgical, stage surgery, and the patient can be, during all this time, can be in every step. Because a patient can be improving when they try, for some reason, when someone try to do the definitive surgery, can go not wrong, not very good, and the patient can go back to the need of a resuscitative intervention, and we must start all over again the resuscitation, and we may go back and forth between these 2 phases. So there is no strict time frame for the phases that we described here. Just for you to know, when you go emergently re-intervene your patient, because that is important. I don't know if your ICUs are open, are closed, are trauma ICUs, are only mixed ICUs, so it's very different. The professionals must to have in mind what they need to do. Because if I'm not in a trauma or surgical ICU, if I don't have the surgical skills in my team, I have to know when I must call them if they don't come every day. In my reality, in my ICU, that is a mix. So I have medical patients, I have trauma patients, I have surgical patients. We don't have the surgical skills inside the ICU. And the surgical specialties don't come from themselves to the ICU. I must call them. I must call every day if I need it. So I must know when I ask for them. Okay, I would like that they go every day. Okay, I'm not closed. It's closed, but we are not closed. We like them to come, but for various reasons, it's difficult. So we must know that the patients only go to definitive surgery when we correct the physiology. But if the patient after 12 hours is not improving, if his physiology is becoming worse, we are not reversing the hypoperfusion, if the patient develops abdominal compartment syndrome, but we should have called someone before we get to the point of the abdominal compartment syndrome, okay? If has other compartment syndrome, there is not only the abdomen, there is also the extremities or some kind of herniation. That is a reason to call the surgical specialties, because they have to decide it. If my treatment is missing something, because it can be missing something because the doctor is there today, is not experienced it, or they have to go to the OR, okay? That is a teamwork. I don't decide it when the surgical team is going to operate. I may ask them if it's time to go to operate, okay? So, and at the end, we have the recovery phase. The recovery phase is the weaning of all the supports, the removal of all invasive monitoring device, the patient and family preparation to the patient go out of the intensive care or intermediate care to the general wards, and also the plans for further convalescence and rehabilitation. So that is what we talk about the damage control phase of the ICU. So now, how can I put teamwork in this if I work in a ICU where I don't have all the surgical specialties in the team of the ICU? How can we improve? So that varies a lot, because Dr. Puyaner, Rian, they have trauma units, yes? So the patients are trauma and there are trauma surgeons are there. But how is it in Greece? Because we don't have it in Portugal, for example, and I know a lot of other countries that don't work that way. But at the end, we want that everybody get the same outcome for the patient. So if we are not allowed, or we cannot get the same system that with the surgical, we have to work with our system. So we depend a lot of different intervenients, it's correct? Different intervenients. So what is this of teamwork? It's easy. It's coordinated activities. It's assessing my capabilities on my place of work. What do I need? Know when to ask for help, support, the others, cross-monitoring, conflict management. That is a little bit definition what is the teamwork and why it is important for these patients, because polytrauma patients normally they don't have only one body region with trauma. In my reality and in all reality, they involve different specialties. For example, the trauma surgeon that we have here, they probably do a vascular lesion, they do a neck lesion. In my reality, the general surgeon don't do it. It comes the ENT surgeon, calls the vascular surgeon for the vessels. Okay, so I have to get the same results to the patient. That is my function. We talk previously about medical ethics, so my function is to get to the patient the treatment that he needs, but I may depend of a lot of persons with different skills. Have the problem that normally we don't know everything about the patient when they enter in the ICU. Do you have radiology 24 hours a day in the hospital? Yeah, because we at night is for telemedicine. And my hospital has 1 million people reference area, but at night the radiology is on telemedicine. It's a company, it's not there. Okay, so everybody look at the pictures, and a lot, for example, sometimes with I believe that is growing the legal things people are concerned about it. So a lot of people wait for the report. Unless there is something very obvious and needs a emergent intervention. On the rest, people wait for the reports, okay? And so sometimes a patient goes to our ICU and nobody assume the responsibility that he has this, that, or that. So that is a problem, but it is the reality. There is no point saying there, no. It is the reality. So that comes this question: who is responsible for the care of the polytrauma patients? You know, that is an important question for each country, for each reality. It's different from my organization to the other country's organization. So every place must ask this question: who is responsible? For me, is the health system. So it's the health system. My Portuguese is a national free health system, so it is the health system that is responsible for the patient. I don't care if it is my colleague or not. No, it is the health system. So we all are responsible for the care. So you can see simply how much specialties I can have involved in my daily basis, because each one of them will say, oh, this is my problem, I can do that, well, but that is not mine. You must call this one, you must call this one, you must call this one. So it's the need for adapt for the reality. And also, I told before, there are very different types of organization. There are different organization and types of ICUs, open or closed. So open, the ICUs are only consultants and different specialties are responsible for the patient, and the ICU doctor is only the expertise for the support. The closed one, the ICU are responsible, doctors are responsible for the patient, and other specialties are the consultant. So it's different. So depends of your organization, okay? That is, and then the type, like I said, it can be a surgical one, it can be only trauma one, it can be a mixed, like in our reality in Portugal, the majority of them are mixed. We have medical patients with trauma patients, with surgical patients, okay? And like I said before, the care must be adapted, but I think the first thing is everybody must be together and decide what is the objective. And after decide what is the objective, they have to work to being able to get it. So during the phases that we call before, there are a lot of difficulties and times where we can improve. So the patient can go 6, 7 times to the OR. And in these 6 or 7 times, it can involve 4 different specialties. So, and sometimes what happens that the patient today is going to close the abdomen, imagine, a simple case, controlled bleeding, spleen out. 2 days, we're able to close the abdomen, and the physiology of the patient is okay, and he also has a fracture. But we don't get them both to go one after the other. No, that doesn't exist, because the inferior limb team of the orthopedics are not working that day. So the patient today is going to close the abdomen, and tomorrow is going to fix the fracture. So he goes 2 surgical times. And if you put maxillofacial surgery or plastic surgery in the middle, if you put vascular surgery in the middle, so imagine how many times, because the hospital governance is not prepared to get the tools to the professionals so they can arrange their daily work plans to the best of the patient. Because if the physiology permits, he could do that in one time, not at the same time, first one, second one, if the physiology permits that for the patient. But the organization doesn't allow it. So we must work on that. We must battle every day for this. Like I said, I don't know if it is the same reality, but I know places where the same reality is this one, okay? Not just in Portugal. So what are the difficulties? Besides the ego difficulties, remember, teamwork is a non-technical skills, so depends of ourselves being humans. So we have the ego difficulties in the first place, our own personality. Then we have the organizational ones, different work plans between specialties. Like I say, nobody's working all days. Subspecialization of the intervenients. For example, we have been in a course last year where we have a colleague from Germany, and they told us that they have the upper abdomen surgeon and they have the lower abdomen surgeon, and they both go. If it is the upper, one of them go. If it is lower, it goes the other. Okay, so the subspecialization, it's a problem. We see nowadays the minimal invasion procedures, and I think everybody feels that open surgery, there are a lot of people that struggles, because nowadays they know how to do everything minimally, but the open ones are still, in the majority of cases, the ones that save the patient. So you have to know to do that important open techniques. Sorry. And also because I truly believe that the main problem is that trauma is not a priority in a lot of health systems. But it's not a priority, it's not only because people don't care, it's because it's different. For example, we know that the casuistic in Portugal or Spain or France, the casuistic of trauma is very low compared with major cities in US, in South Africa, or South America. So it's not a priority because it's not a problem. It's a few. So for the politicians, it's not a problem. They think it's expensive to create something that it occupies a little time. So it is our way, our responsibility, try to alert them that this is normally young people with a long life along. It's a major cause of mortality and morbidity in the young. So it's our work to show. So the way that we can improve is to share the responsibilities. We can try to organize daily rounds that must include all the specialties at the same time, because normally I talk with one at 10 o'clock, at 11 appears the other specialty, at the noon appears the other specialty, and we are not able to prepare the plan of care at the same time. And maybe we should start small, define small objectives, small steps to get to a great result, even not to go at the end, because we may not get there. So we must start slowly with some objectives. So I remember an opportunity of improvement, that is using the tertiary trauma survey as a tool of teamwork. So for you who doesn't know, tertiary trauma survey is the objective is to find the missed injuries. So this article is from last month, I guess. So it's still a problem, it's still a reality. Okay, you don't find everything. You must know that we are going to miss injuries at some time. The majority of them are not risk of mortality, but there are also lesions that we don't find that could cause mortality. For example, for the great vessels are one of the major risky ones that are missed, like in the spinal column. So they exist. The tertiary trauma survey is a tool that was created to guarantee that you don't miss injuries. That was his objective. So the purpose was to prevent, ensure there is a complete diagnosis, improve the patient care. Its components are the physical examination, the review of all the imaging investigations reported, and also the images, complete anamnesis, repeat the examination for specific patients. And ideally, it should be completed within the first 24 hours. And after the situation of the patient improves and after the patient wake up. So the objective was to search for occult injuries. And in developed countries, where the trauma system is very advanced, what they are testing now is to not being doctors doing it, but for example, nurses or technicians. And they are showing good results. But I look for it like another opportunity. What if in your country where you don't have a trauma system, you define the tertiary trauma survey as a national standard of care, and you increase and you add the need that at the end of this exam, you can call it other name, I just use, it must be put the definition of the plan of care of the individual patients and all the next steps. That demands that all the different specialties that are involved must to address and say what they want to do, what they need to do, and when they need to do. If that was a standard, everybody knows that has to do it. Everybody would create the way to do it. It could be a small way of doing it. It may not work for every places. It may work for someone that is starting and wants to get to a better outcome, a way of demanding the organization of the teams. So it was my small idea when professor asked me what I could bring. So thank you. Yes. Accidents, falls, mainly non-penetrating trauma patients. There is a very few numbers of penetrating trauma cases, and mainly in the biggest Lisbon or Porto are some, but in the majority in the country, it's less than 5% of all. But it's the reality all over Europe. We have a lot more non-penetrating than penetrating one. So in Portugal, the emergency room is ICU responsibility. So ICU, the leaders of the resuscitation rooms, because the resuscitation rooms are mixed. So it's for every critical patient, not only trauma. Yes, everything comes and they are responsibility of the ICUs. So we are open. We do the resuscitation inside the hospital and in the resuscitation room. So it started next year. It was approved this year. The residents will start next year. And the first emergency doctors are by consensus, like myself. I'm also waiting for the result of the consensus because they need someone to train the new residents, okay? But it's only going to start the next year. And the emergency doctors for now in our plan are going to be the responsibles for the B assessment in the trauma team. With a trauma, yes, always. We call them, always. We alert all the surgical specialties that we may need. We work as a team, and when we have the meetings for trying to organize our trauma team, because it's difficult not being a surgeon and being involved. They are very kind of our collaboration. Yes. Yes, to the air. They are responsible for the airway in the trauma team. Yes. But it's a fight. They don't want to come. No. No. Sometimes we got surprised, but the pre-hospital system, it's not pretty good because we have doctors specialized for pre-hospital treat, and they are from all specialties, even without specialties. So the skills needs to be, but the organization, the alert, the calls it's done. We get the alert. The ER doctor gets the phone call from the pre-hospital system. But they don't use, for example, ATMIS. So sometimes the information comes the way the people is talking. Remember, there is no standardized transfer of the information. That is also a step that they should improve because they are outside the system. They are independent, are public, but are independent institution. They do guidelines without talking with the National Medical Association. So it's a little bit confused sometimes. Yes. No. No. In our practice, no. We treat what we find, but I know places that have different ways of working, and we also are not very protocolized. Okay, that is the reality. I don't know if it is a Latin thing, but we are not very protocolized. We do it day by the day, case by case, and a decision of the person that is in the day.
Other question from
I don't know. I don't know. It is in Greek. I don't understand.
Just names. There are just names to take the certificate. Yes, they cannot communicate. They cannot make an agreement. We must treat them because we are humans. That's the priority in my mind. The same applies for those that has acute head injury, acute stroke, or myocardial infarction. All of those people need a special care, special treatment, which should be given if our society is humane or not. So the next speaker is Juan Carlos Villana. Yes, yes, that's the order. So Juan Carlos is
here on a Sunday morning. You should all be in church or at the beach. So I'm going to try to make this as entertaining as possible, but I'll be brief. I was asked to talk about what we do in Pittsburgh, how we do it. And I think it's an interesting way of learning from each other. So I'm going to limit this presentation to sort of the everyday running of the trauma and acute care surgery service at the university. As always, I don't know how to pass this slides here. Just click. There.
not the cursor.
It's all in Greek. Where is the oh, there it is. Okay. In 2019, I was here with Fontales and Professor Janis. He is proud of showing the place where we train the future leaders of trauma in Greece, and I'm delighted to be back. We all look a little aged, but happier, I think. So thank you for the invitation. Thank you for the pleasure of coming back. This is Pittsburgh. The two rivers that you see there are the Allegheny River on this side of my left, and the Monongahela River on the other side. When they come together in that corner, the Ohio rivers form, and the Ohio Mississippi River basin. This is interesting because this is where the United States sort of began to expand with the Franklin Lewis expedition 300 years ago. The Monongahela River is the longest river that runs from south to north after the Nile. No one knows that except if you live in Pittsburgh. That's the first thing they tell you. By the way, anyway, Pittsburgh is located on the opposite side of Philadelphia, about 6 hours driving distance from the East Coast. So even though it's an eastern city, it's a lot more rural than what you see on the East Coast of the United States. This is the hospital. What am I doing? Oh, there it is. This is our trauma center. The big building is in the back there where the flag, the helicopter lands on the 13th floor. This yellow building on the left is the Faculty of Nursing. That little building down below is our outpatient clinic. And that building with the red roof is all research laboratories. We cover about half of the state of Pennsylvania. We have 18 bases. I have to update this slide. And about 23 bases, 18 helicopters. And sometimes it works. There it is. In trouble getting the... This is going to be very painful. You see those three circles? That's half of the state of Pennsylvania. That's what we cover. Our hospital has about the same amount of beds. So this hospital, about 800, but 160 of those beds belong to the ICU. We cover part of West Virginia and part of Eastern Ohio. And we get between 5,000 to 6,000 trauma patients a year and about 4,000 emergency surgery patients a year. The trauma center was created in 1986. So it's more than 35 years or so more since it began. And the motto is there. There is no higher honor than human service. To work for the common good is the greatest deed. So when you listen to Pantelis talk about the reason to take care of patients who have acute injuries, acute illnesses, we have the same motto. This is the group of people that are working on the trauma center today. We're getting old. I don't know if I can point here. Anyway, the woman with the glasses on the right is Raquel. She is the medical director of the trauma service. The vice chair of surgery is this fellow with the bald head. That's Brian Zuckerbrown. Sperry is that fellow in glasses behind the two ladies. He leads the division of general surgery, and Sperry is one of the prime investigators of clinical trials in the United States in trauma. He has about $90 million in grants just to do clinical trials in trauma. Maki, that young fellow on the right, has invented a synthetic platelet and also has about $20 million in grants. So our team, most of us are clinicians, most of us do clinical care, but there's a powerful group of people that are heavily invested in research of all kinds. And that makes the Trauma Center at Pittsburgh probably one of the pioneer centers in the United States for researching and clinical investigators. One of the interesting things is that if you look at this picture several years ago, we're the same. Once you land in picture, you don't want to leave. You're happy there, except for Matt Rosengart. Everybody else in these pictures is the same, except that this guy here, it's Andy Peitzman. He's retired now, but he is my boss. And it's a guy who's a pleasure to work with. He makes sure that if you're not clinically busy, whatever else you're doing where you're not clinically busy, you're happy. So Andy was a genius because he made sure that each and every one of us do whatever it takes to be happy while you're taking care of patients. And I think that's sort of the mastery of leadership. We have 32 beds in the trauma ICU. That's without counting the neurotrauma ICU. There are 10 more beds just for neurotrauma. There are 12 attendings and 4 surgical critical care fellows. So 4 fellows who do a year of ICU and 2 additional fellows who do 2 years. So at the end, we have 14 attendings. The team is formed by residents. There are 6 mid-level practitioners and 3 trauma nurse coordinators. So it's a huge amount of people that help us run the trauma service. Very different of what you see in other places. When you look at the amount of ancillary personnel that is needed to run this service, it's an army of people. We couldn't do these without the help of these nurses. These nurses are like high-level interns. They see the patients in the morning, they write the discharge orders, they make sure everybody goes home with DVT prophylaxis, they make sure that everybody goes with follow-up. The residents are not enough. So without the help of these mid-level providers, MLPs, we couldn't run the trauma service. Each of us has an elective block about 1 day a week. Most of us do general surgery elective, cholecystectomies, hernias, abdominal wall repair. But the reality is that the emergency room is so busy that we probably can keep the operating room scheduled just by doing what comes through the emergency room. A little bit of history about Pittsburgh. The richest people in the world lived in Pittsburgh about 150 years ago. Every mega construction of the first half of the 20th century was built with steel coming from Pittsburgh. The Golden Gate in San Francisco, the Empire State in New York, all those amazing constructions were made with steel that came from Pennsylvania. And these were the people who made that possible. Carnegie Mellon was one of the richest men in the world. So was Carnegie, and the Mellon was the bank who run his business. So most people think that Pittsburgh looks like this. It used to be that way in the 70s. It was quite a city scarred by heavy industry, iron processing, charcoal, and steel mills. These are gone. Pittsburgh now is a really beautiful city, surrounded by nature, very rural in one sense, very quiet. It's actually filled with nice neighborhoods. And in the middle of it is the university, which is an incredible facility founded in 1787. And it's got, a lot of attractions. So the university is the number 5th university funded by NIH in the country. We're below that threshold that now Trump is trying to kill. No one knows who we keep the head of the fox inside the foxhole, because the university is not as recognized at Harvard or Columbia, but in sense of NIH money, is only number 6 in the country. If you live in Pittsburgh, you need to understand American football. I don't, so I'm always in trouble. Gosh, I cannot pass the slide. This is the Pittsburgh Steelers and the Pirates. I don't know why I can't. Oh, there you are. This is and we got 4 seasons. Nice winter with climate change. This is changing, but the city was well taken care from those endowments from all those Carnegie and Mellon. So there's a lot of art and entertainment there. We show these to the fellows knowing that they're never going to be able to enjoy because they have to work in the hospital, but that's how we bring them to Pittsburgh. They're attracted. Come listen to the opera, but you have to be on call. Anyway, we have an amazing pre-hospital system. The helicopters I already told you about, but the EMT system in Pittsburgh is actually quite robust. Rescue training, communications, stat medevac, and the commander's office, all is sitting at the Presbyterian Hospital. So when you get a trauma, we actually have tremendous information pre-hospital. These are the locations of all the bases. Some of them are even in Maryland. The company that runs the helicopter takes care of trauma transportation, not just for the University of Pittsburgh, but even some medical centers in in New York. That works very well. And right now, in front of this green zone, right there, they're building this amazing tower, which will be ready maybe in the next 6 months. So the university is going to look like this, and that is going to be a brand new hospital that I hope you guys can visit. It's actually quite an interesting place. The trauma service has been there for 35 years. The trauma attendings are the ICU doctors of the trauma unit, so we are the same people. Unlike what Mauro was saying, when I'm on call for the unit, I don't operate that week. I am a 100% ICU doctor. You're not allowed to book patients. You're not allowed to see any surgeries. You do ICU care. And then the week after, people switch. So the surgical care, the critical care for trauma is provided by the same trauma surgeons. The system is rather large. In Pittsburgh, there are 3 trauma centers. One is the Children's Hospital. The other one is Mercy. And the one that I work, which is Presbyterian Hospital. And there are 4 more trauma hospitals about 300 miles in the half west of Pennsylvania that also depend of our trauma center. So if you count all these, the UPMC trauma system is probably one of the biggest in the United States. At 3 o'clock in the morning, when you think you can go to sleep, you get these. Level 1, estimated time of arrival, 7 minutes, 19-year-old man, multiple gunshot wounds, blood pressure 84, heart rate 142, unresponsive. So we're lucky that way because most of the time we have good quality information about what is coming. And you have 7 minutes to get your team ready, which is quite impressive. And we're happy that things work that way. This is our schedule. So you can see on the right, on the left, the names of the people that cover the ICU. We have 4 services. And in the morning, the chief resident prints this page with every single member of the team on the left, with your phone number, who is on call for chief resident, junior resident, intern, what is the operating room schedule on the left. And they have that list on the right with all the admissions from the night before. So at 6:30 in the morning, we do sign out, and the team that is leaving the evening introduce the day team with everything that came during the night. You never see anyone again after 7 o'clock in the morning. People disperse and everybody goes to work. But this half an hour at 6:30, it's fundamental. If we don't get together at 6:30, the whole system breaks apart. This is the most important moment of the day. That's when everybody knows what everybody else is doing. The chief resident, you go to the OR, you help with the robot, you go to the trauma bay, blah, blah, blah. We have 4 services: red, blue, gold, and silver. Red and blue is trauma. Gold and silver is acute care surgery. These are the nurses, the mid-level providers, and these are the nurse coordinators. This is amazing. I haven't seen the list together. Denise, Amy, Lee, Paul, Stephanie, Dee. They don't do any clinical work. All they do is making sure that we do our jobs. They're a pain in the neck. They round with us. They make sure that all the pieces of, these are the people that is in charge of making sure that all the documentation is filled. So when the Pennsylvania Trauma Foundation comes to recertify the center, everything's in order. I think I already showed you these. Every 4th and 5th year resident, and before they start on the trauma service, they go through an asset course. So they do cadaver dissection and exposure, and they're all supposed to read these books. Just kidding. The book on the right, the trauma manual, is a handbook of the University of Pittsburgh that was published by Peisman, and it became a book that everybody uses. This is what the interns carry in their pocket, that trauma manual. All the protocols that are sort of for immediate care are there, and he's written a number of editions about that. These are the level 1 trauma team activation. So these are pre-stipulated key parameters that everybody needs to know. So when you get a phone call saying that the patient is coming, you'll be able to classify and make it a level 1 and a level 2. Why is this important? Because depending on who you call, depending on who you designate, then different people will come to the trauma bay. In the trauma bay, everybody has a position and a designation. There is a respiratory therapist, there is an X-ray technology, there is a CT, there is a social service personnel. They're not there for every level response, but these are the sort of basic army of people that is in the emergency room supporting the trauma team, and that works really well. And when the residents start the service, they're given this little handbook where they know what the responsibilities is. If you are the primary resuscitator, what you need to do. When do you talk to the trauma attending? Where do you stand in front of the patient? It's criteria from the ACLS, but that's what the trauma bay looks at the end of the day. One event that we have at least once a year, we have a gathering, a social gathering, and have those who survive major injuries come and meet their doctors again. This is an interesting activity because it bridges the trauma service to the community. The community knows this is fundamental. The community knows how important it is to have a responsive trauma service. So I don't know if you remember, there was a crazy guy with an automatic machine that entered a synagogue and killed about 14 people and injured another 20. Well, the policeman on the left with the green shirt and the rabbi on the right with the blue shirt were two of the most badly injured people at the synagogue multiple casualty event that was operated by the trauma team. And these survivors come to a nice room in a hotel, and there is a little celebration, and that comes in the press and the newspapers. And that has a tremendous impact because people know who is in the trauma, what do we do, and the community and the society understands the value of that. I told you everything about the research. 2 or 3 of the most important pre-hospital trials have been done at Pittsburgh with help from other trauma centers. We have whole blood in the helicopter. We have plasma in the helicopter. We have tranexamic acid studies. Okonkwo, who is that fellow in the middle, is the head of the neurotrauma unit, who is also one of the pioneers in traumatic brain injury research. So the academics of the trauma service are quite powerful. When Pantalis is building his army of trauma doctors in Greece, he needs this little map here. He needs to look at the medical student and ask himself, is the medical student crazy or is it sane? If the medical student is crazy, you need to figure out what kind of attention span the student has. If the attention span is significant, that fellow should go to psychiatry. If there is no existent attention span, that fellow should go to emergency medicine. So remember that motto when you start training your people. If the medical student is sane, the first thing you ask is, are they hardworking? If they say very much, then you got to check the attitude. If it's not hardworking, you go all the way down and you say, are you afraid of the light? Then that guy should go into radiology. Are you afraid of the dark? Then you ask them, do you think big? It should be a dermatology. If you think small, it should be an ophthalmologist. But what about your attitude? If the attitude is nice and you hate adults, you should be a pediatrician. If the attitude is nice, but you hate children, you should go into medicine. If the attitude doesn't matter, then you say, how do you like your patient? Sleep? Then you go to anesthesia. You want your patient dead, you go into pathology. If finally you find a hardworking with a mean attitude, that's a guy who goes into surgery. So this is a little map for you when you start choosing who else is going to help you in this endeavor. Just a little philosophy here, 2 more minutes. I wish we use this word more often in the English language. I don't hear it very often. Adroit. How do you pronounce it? Adroit. It refers to a person's ability to effectively and efficiently navigate challenges, solve problems, perform tasks with dexterity and expertise. Someone who is an adroit is often characterized by their agility, resourcefulness, and quick thinking in dealing with complex or demanding circumstances. I think that's what we try to do when we do the VSTC. I think that's what we are looking for when we want people to work in trauma along our colleagues. And I think we need to make a special effort on cultivating and mentoring those who show these when they're young, so they actually become successful surgeons and ideally successful trauma surgeons. I'm going to stop here. I think I was going to talk a little bit about Colombia, but I leave that for another talk. Maybe end with this slide. We ask every resident to read this book. It's a book written by Mattox. I saw Mattox last week in Boston. He's close to 90 years old. I've met him many, many times in the Pan American Trauma Society, but this time he didn't remember me. So I think he's, like all of us, is kind of, time goes like that. This is a sentence that comes from bullfighting. Ria, you were asking me how barbaric it is. The Spaniards said, if you take death away from bullfighting, there'll be no fear. If there is no fear, there'll be no tragedy. If there is no tragedy, there'll be no art. Trauma is the same. The way we feel how important our job is because we're facing death and we need to be good at taking care of them. But at the end of the day, everybody tell you your CV should like this. Every step carefully planned across a beautiful river so that you know how do you go from alpha to omega. That's Malikia. What is it? Malakita. My CV looks like this, but I made it to the other side. So don't worry about it. If it doesn't look like this, make sure you get across the river. If you come to Pittsburgh, I even make a paella for you. Thank you. And you're welcome in Pittsburgh. Thank you very much. Yes.
I have seen your presentation one tremendous number of high transportation in trauma patient. It's how it's I want to ask about the area that we cover. I have seen the 15,000 patients taking in total. It's really
The area is
so
about
tremendous. Yes,
it's about half of the state of Pennsylvania.
and the population.
Well, I
To compare with the Greek reality for this, I ask.
birds, all the people that live around, but how do the state of Pennsylvania, five or not, 5 days?
Increasing the urban population of the 11 million, we have 10,000 per year for this medicine. And there are some protocols, if you saw of the choice of helicopter transportation of the ambulance. I have asked about the protocols that you use for the use for helicopter. Yes, it's possible.
George Brown, who's one of the guys in that picture. Who is the head of the helicopter program. And with Frank, who's the emergency minister, the program is led by emergency medicine and surgery. And they have all that documentation.
Very good.
George has done tremendous research on what the techniques of air transportation. He's a computer genius. He's done all kinds of studies about kilometers of distance, medical care, sort of justifying and supporting the need for the health to make it sustainable because it's very expensive. So what formula would be most effective in Greece probably would be very different from what works in Israel, but I think learning from what they do there would be helpful.
That's really deep, man.
Yes.
Professor, give us the form of the Supposed
I will make the paella for you, even if I have to come bring it here.
Will you be willing to show slides? I think there's so to talk about it. But not as a book of that. Thanks so much.
Hospital is a private hospital, and the other one is the government hospital I work in. I'm sharing the same difficulties. Okay, so this is our private hospital. Unfortunately, you can't use the cursor to show on it. So we've got the private hospital is about the 800-bed hospital with 180 ICU beds. After 180, we've got a 30-bed trauma ICU, 30-bed burns ICU, and an 8-bed trauma high care. The front part of the hospital is the furthest in the photo where the emergency department is. So here you can see the emergency department, the entry to the emergency department with the 2 helicopters. We don't have a fancy roof that they can land on, so we have to push the stretcher like normal through the normal area. But if we can even land 3 helicopters at one stage. So we are quite good to the system that we can make a plan when we need to. So just to add on to how trauma systems work. So Milpark was started by Professor Boffart, and he put all the systems in place. And you can see how progressively our P1 patients are just getting more. And the reason for that is that we go out at least once a month with our trauma director, the pre-hospital personnel, and at least 2 trauma surgeons to all our referring hospitals. And then we do the teaching, we explain to them what we're doing, and they buy into the system. So what we want to do is we want people to buy into the system and send us the P1 patients. We don't really want the P2s and P3s. If they come, we treat them, of course, but we want people to refer their patients to us. So when you look at, we get about, I would say 60 to 90 P1 patients a month. And what of those patients, what we do is that we must make sure that, about say 60 to 70% of them is actually referrals from another hospital. You'll see that and what we also want to do is we want to educate also the pre-hospital personnel which patients should actually come to us. And then what we do is, so if you look at the difference in the trauma that we get in private hospital, penetrating is a lot less and blunt is a lot more. And then we get our burns patients also. So when you look here, I think the whole purpose of a trauma system is to if it goes to the right place, is to ensure better outcome for patients, to make sure that we actually start to look at the unexpected survivals, and what we use is the injury severity scores. And I think the unexpected survivals show that sometimes the system is working. So, and we give feedback to the hospitals that actually refer the patients. So when the patient's admitted, we give them regular feedback. When you have our M&M, so you have once a month, we have a M&M, it's online. And we got probably about 170 participants. But if a patient started in the hospital, we invited that hospital also. So then it starts from the hospital, the transport service that brought the patient to us, and then it ends up with us and what happened when the patient was us. So we tried to make a closed loop so we can discuss at every stage where we could have actually have done better for this patient. So, no, sorry, I'm not sure that's done now. Sorry.
Sure.
Just ask me, Sherry. I'm just getting to this. Okay, sorry. So in our ED, we've got 5 resuscitation beds, which are shared by medicine and by and trauma. So we try to keep at least 3 of them for trauma. In our emergency department, we always have 4 units of blood and 4 units of thawed FFPs ready. We don't have the luxury of whole blood due to blood shortages in South Africa. The thawed blood, if we don't use it, we send it into the cardiothoracic theatre so that they can actually use it, so we don't waste it. We've got 14 cubicles to see P2s and P3 patients. We've got a Lodox. I'll show you now the Lodox. And then we've got a CT scan. Our CT scan is basically probably 2 meters from our resus bay. So you just open the door and you push the patient into CT scanner. So this is how the Lodox look like. So as I said, we've got a Lodox scan. This is our Lodox scan. When any patient come in, we also got a Lodox at Barrow. Any patient come in that's stable, the patient go on the Lodox immediately. If they're unstable, we take the patient to the resus bay and we do the interventions that's necessary. So when you do a Lodox, it does basically a top to bottom X-ray, and you can see immediate life-threatening pathology. So you can see if there's a pneumothorax, a hemothorax. You can see whether there's a pelvic fracture. You can identify, you can see the femur fracture there. So what we actually use is that we immediately have basically a full body X-ray.
Radiation do you get?
So it's a very low radiation. So the Lodox actually started off in the mines where they, when people leave the mine, they had to X-ray people to make sure they didn't swallow gold or whatever, try to smuggle it out. So that's where it started actually from. It started from the mines, and then we started to use it in medical terms also. And then what we did also now, we've changed to, I'm sure Prof and them are already using it, but electronic because record keeping. So we now on the care. I don't know if they just randomly pick them or they just everybody that goes through. Yeah. I think they picked them randomly. So we basically got now this electronic system where you can sit at home and you can prescribe medication. You can see all the vitals. You can make notes. You can actually, you can follow. So if the sister's phone you and they want pain medication, you can just go and prescribe it. You can see all the vitals. You can see all the X-rays. During the recess, they take photos of all the injuries and you can see. And then, so if I then consult a orthopedic surgeon or everybody else, then I actually can see it immediately, the injuries and the open fractures and everything else. And on their own scan, I just associate them with the patient. And this is a Lodox of a patient that. So, no, that has actually been used by all the doctors in the hospital. So all the doctors. So if I want a cardiologist and I assign him, he can see everything about the patient also. So the patient was referred to me from another hospital also, a Jehovah's Witness, multiple long bone fractures. So he basically broken his elbow, his femur, everything. They also did even it was very nice and did the X-ray also of a diaphragmatic hernia, arrived with a HPL3. We took him to theatre and fixed his diaphragm. He stayed in hospital forever, couldn't fix his bones, but he survived and eventually was out of the hospital. But we couldn't give him blood and he went into renal failure. We gave him Venofer and erythropoietin. He developed pancreatitis, deised his abdomen, but he came even for component separation back. So talking about the heli service, I think the one thing that we really got nice in the heli service, we don't have 23 helicopters, or we actually only got 2 helicopter services. We used to have 3, but I think they decided the other one didn't make it. Sorry. And what we've got is we've got very good communication from the helicopter service. So they will send us a message on the group and say, listen, they're fetching the patients. This is the injuries the patient sustained. Obviously, don't use the patient's name or anything that identify the patient. Then they will tell us, okay, they're going to land at the hospital where the scene, if they do a primary, this is the time they're going to land. And then they pick up the patient. And once they stabilize the patient, we've got paramedics that can intubate. So it's part of their protocol also. So the patient needs intubation, then they will intubate the patient. And then on their way back, they will send us the vitals and say that we will be landing at your hospital at this time. So they share all this information so everybody knows exactly when to be ready. The nice part of it is they say they need to do a hot offload. They can say you need to prepare adrenaline, get blood products ready, prepare your theater, or we need to airway, get your airway stuff ready. So it's very nice that you can be prepared by the time the helicopter lands. So now this is my real home. Chris Hani Baragwanath Hospital. There's quite a few familiar faces that was there before. Some of them smiling. Theo is getting shivers and cold sweat about Chris Hani Baragwanath. So if you look at Chris Hani, this is our recess bay. So we can actually have 16 patients in recess. We sometimes double up even with the recess bay. So you can see all our monitors is at the bottom. We have our recess bay, nursing station. We've got a blood gas in the back there. We've got also a fridge with emergency blood is in the back there also. On the side closer to us is where our Lodox is at the door when you come in from outside. So this is our recess look on a very rare occasion. Then it becomes night. And after night, this is how a recess looks like. So then it really starts that we're really getting busy, and you can see that there's we can ventilate up to 6 patients in our resus area. Then we close because we can ventilate more, but we try not to because we never know when we're going to receive someone that needs ventilation immediately, and we don't have ventilated then. So, and then sometimes if you're triaging and it's a P1 and it's not your turn, you're going to have to wait your turn because it's full. Sometimes even the side wall on the side is full of patients because we don't have enough space for them. So if you're hopefully not going to die while you're waiting for your resus. Then this is our outside area, P2, P3 area, triage area. This is like organized chaos. And usually what happens is you think you're just clear, and then they just like they arrive in waves. So when you think you're just clear, then there's the next wave that's coming. And this is like how it looks in the outside area. The cubicles is there. Most of the patients outside the cubicles because we don't have enough space for them in the cubicles. So what do we see? We see in a weekly day about 800 patients in the trauma emergency department. Of that, 80 to 100 trauma ward admissions in a week. We see 8 to 12 trauma ICU admissions in a week, 80 to 120 major trauma resuscitations. So we do 60 emergency trauma operations, with 15 of them probably major. We've got 40 EFAS. I think it's underestimated. Of course, almost everybody get EFAS now. We do 120 LODOC scans, about 20 IC drains in a week, and about 30 central lines in a week. So you think it is all not busy enough? Then our neighboring hospital, Charlotte, decided to burn down. So so we got 2 level 1 trauma centers. I will not do my unit justice if I don't say the smaller unit burned down, but did we feel the impact? We definitely did. So when Charlotte closed, we saw 140 to 180 resuscitations a week. We did 600 to 800 P2s and P3s a week. We did 50 to 20 laparotomies a week. We did 4 to 6 stab hearts a week, and we did 4 to 6 vascular cases a week. And basically, we admitted basically 160 patients a week also. So if that wasn't bad enough, then they decided to lock our ex-president up because they say politicians is corrupt. I mean, nobody would say that. And then the people decide to take the law in their own hands, and there was massive riots in South Africa. So what happened was I came in on the night of that when the riots started. We did that whole night from 7 to 7, 10 laparotomies. And there was still, the next day we handed over another 10 laparotomies. And you can see the cases we compared it to the previous years, and you can see the drastic climb that we actually had on those days with the riots, or the day of the riots, actually. It was 2 days that really was bad. And then you can also see the comparison in penetrating trauma, what we saw in that time. So you can see gunshot wounds, 65 gunshot wounds in that time. So I'm not going to go too much in further, but what do we do? So the first part in the private I showed you because that is like where systems work. Now we are in Barrow, where systems don't work, it's a damage control. Everything is damage control. You just try to work through everything and be systematic. And we just stick to our ATLS. I'm not sure why the slides are not moving by themselves. But what we do is we stick by ourselves. So what we do is we do our own, the airway protection. You can see this patient. And probably the best way to protect this airway was we did nothing. We took him to a theater, and then in theater, they controlled his airway. We stick to the breathing part. And you can see intercostal drain, massive surgical emphysema, and intercostal drain. And then here's where the fun starts to, like, we look at the circulation, the bleeding, where the trauma surgeons are probably the most active in. Obviously, you have to look at your C-spine and exclude C-spine injuries. But you have to expose your patients also, and to prevent hypothermia, and to look at, we always add up all the bullet wounds. So your bullet wounds must be equal. If you're not equal, then you must miss a bullet wound. And we also exclude back wounds. And then we stick to the adjuncts that we normally do. Part of it is also now the EFAS that we use these days also. So the EFAS that we use, that we all know now, which stands for Extended Focus Sonography assessment with sonography and trauma, where we just see if a patient is bleeding or not. So if a patient's unstable, so how we use the EFAST is, so the E part is that we look at the chest, we look at the pneumothorax, we look at the pericardium, and then what we use it, you can use it as a primary tool. Primary tool is the patient is unstable, EFAST positive, go straight to theatre. Patient is stable, EFAST is positive, then we'll do further investigation, CT scan on these patients. And then surgery, that's where we spend most of our time on when we work with. So it almost looks like Prof's resus bay, but this is how our theatre looks like after we're done. And here's a patient with a stab precordium. It's another one. We do the EFAST, and you can clearly see the fluid around the heart. Patient is hypertensive. And here's two of my colleagues doing a stenotomy. Dr. Mauser, Prof. Prani, was he doing a stenotomy for a stab heart? Stab heart. Here's emergent thoracotomy where they stuck in two Foley catheters in the patient. And then here is, can see the knife into the neck and an exploration to remove the knife. So what we do is in our trauma setting, we basically operate the neck, the chest, the abdomen, and do vascular cases from the neck, subclavian, brachial, femoral, but we don't do popliteals. It's the only part we don't do because of the poor outcome. So Prof. DeJohannes, who started the unit, made a rule and said that we're not going to do popliteals. It's a thing that if you ever come to Barrow, you'll definitely learn. We used Foley's catheters in bleeding neck wounds and you can even use it in bleeding thigh wounds or any other wound, is that we put a Foley's catheter in the neck to tamponade the bleed, to give us time to go to theatre, to go and do a neck exploration. So these are all the fun ones. Unfortunately, we do spend a lot of time in the abdomen. I think most of our time in the abdomen, which is where we basically, because of the number of resusces we see, and our resus numbers is 60 to 70% penetrating, which include gunshots and stabs. So we actually spend 90% of our time in the abdomen, and the other time we basically do all the vascular stuff or the neck stuff or the stab heart stuff. So, but this is the majority we do. On a normal week, about 10 laparotomies and maybe 2 vascular cases or 2 stab hearts in a week. And then my last slide. This was the first time I came to Greece, where they first lied to me because they said it doesn't get cold in Greece, and we landed here and it was snowing. So they lied to me. So we had to go quickly and go buy jackets. Yes, Prof. DeJohannes, my previous boss, got a lot of respect for him. Yes, Pantelis, Dietrich Doll, Dave Muckett. Who else is there? And there's me. And that's it. Thank you very much. Any questions? No questions? Good. Thank you. Yes. Yes. Yeah. Yeah, so they're back to where they're working now. So what happened was that they take referrals. So there's 2 tertiary hospitals that do trauma. There's only 2 of us in Johannesburg. So they take a lot of referrals from the East Rand and the east of Joburg. We service the south of Johannesburg. So obviously what happened, because they condemned the building, so they couldn't work in the building. So then we had to take the whole of basically Gauteng, or take all their workload also. Yes. Yes. So the burn unit has expanded now. There was a McAlpine Foundation that actually sponsored money, so private sponsor, who they increased the size of the burns unit. So now they actually got 12 ICU beds. They got more ward beds also. They now got, it's not every day because they don't have the full capacity. They got patients to they got medical officers to cover some nights in the burns unit also. So the biggest problem in South Africa, because it's a poverty country, and you can see in poverty countries, people use primitive ways of keeping warm in the winter months. So they use paraffin stoves and fires and whatever. And then our burns numbers just drastically increase. Then probably half of the burns patients go to the burns unit, and the other half get managed by us because there's not enough capacity in the burns unit. So unfortunately, during our winter months, you spend a lot of time debriding burns wounds and skin grafts and all those things. So that is unfortunately just a disease from our, you can divide, South Africa is like third world country with some rich areas, if I have to be honest. Yes.
I mean, patients in need
So in Milk Park, we'll say about 80 to 90 P1s in a month. Paraguay is probably 400. Yeah, we see 80 to 120 a week. Yes. And I can assure you on a month and weekend, I'm sure they can tell also, there's lots of them that need to be in P1, stab chest, that we send them do an x-ray and say it's fine, and then we leave them outside because there's no space. So there's lots of people that will qualify fractured femurs, fractured multiple polytraumas, that we do a fast, we load ox them and then say, okay, do a gas, blood gas, and if they look stable, we send them outside. Then they don't wait. So they don't, no, that's in the P2, P3 area. So then they don't get counted as P1. So if you're really going to count on mechanism and on injury sustained, then I think that we probably could add another 100 a month.
They started given in 1990 and they stopped in 2000. And it was the sign of Barbon, the hand, an injury to the heart, then stitched to the heart, and spoken. And this was due to those completed 100 subjects with the heart, and the patient was after that. And after 10 years, everybody had
Yeah, maybe we'll restart it. Good, thank you.
Trauma system in Greece. Ορίζουμε τι είναι τραύμα, αν και τώρα πια με όλα αυτά θα έχετε καταλάβει πολύ καλά. Ένας άνθρωπος πεθαίνει, δεν είναι απλά μια γρατζουνιά. It's a serious injury that will diminish the future of the victim for severely, so he will probably die in a few minutes. It's the most urgent of the urgent, and the same applies for other problems, other diseases like stroke or acute myocardial infarction. So these are the most urgent of the urgent cases. And according to this definition, we should do fast what we have to do, because after a few minutes, the brain that is hypoperfused will create a donor and not a human being anymore. So we must be rapid in whatever we do. And this shows the red line shows the cases that yes. The red line shows all the period of treatment of those patients that we need to be fast, and starts from the beginning of the incident when the time counts. Should be transferred to the hospital as soon as possible by helicopter, by car, but within a few minutes and not hours. If it comes after 6 hours, it's meaningless. The patient would be dead. So we need to be here at most in an hour. And after coming in the hospital, goes to the area that's called resuscitation, και όχι ανάνυψη, that it's called in Greece. Ανάνυψη means to recover after anesthesia. And resuscitation ή αναζωογόνηση means to give him back the life that is slipping away from him. And after resuscitation area, the patient goes to the operating theater or ICU or emergency radiology to do an embolization. And after that, the patient that, if he's still alive, probably he will remain alive and goes to the ward and then to the recovery area. So the red line ends at operating theater or ICU or interventional radiology. We have a lot of trauma in Greece, mainly road traffic accidents, and most of the victims are by the age of 40, like in the rest of the world. This guy do a lot of effort to create a registry, had published 3 papers. It was back in 2008. The interesting thing is that in that era, we give time in the resuscitation area 88 minutes average for the patients. The patient would be dead 4 times in 88 minutes. In the normal world, they spent 15, 20 minutes, not more than that. Additionally, the patients that was treated this way were transferred to another hospital for a better treatment who has exactly the same expertise as the previous hospital. So this underlines the lack of experience to treat trauma patients, and of course the lethality of these treatments was very high. Also, another interesting outcome from this study was those that knew ATLS has worse outcomes than those that didn't have ATLS. This is totally to question about what is going on here. And this comes from the European Union 2021. Each of those surfaces is analogous to the incidence of the problem. So you see that the strokes and the acute myocardial infarction are the most of the diseases that are a problem for Greece. And these patients should come as fast as the trauma patients to the emergency department because they need also to be treated immediately. Otherwise, they will die or have severe consequences for their health. This also comes from Europe. Greece is the 5th worst country in road traffic fatalities. And the other 4 countries that are worse than us is the countries of the ex-Russian επιρροή, ex-communist countries which drink more than us. And this is why they die more and have worse road traffic roads. This is a study 2023 from European Society of Trauma and Emergency Surgery. Greece, as you see, is the worst country in Europe treating trauma patients. This is not honest. We are below Bulgaria, which I know is worse than us, but we say the truth. Other countries probably make things more good than they really are. So what do we need? We need to bring fast the patient to the hospital, which means we must involve something that comes fast, like a car, like a helicopter, and a system that will create this transportation as fast as possible. In the hospital, we need a resuscitation area, and not ananipsy, the resuscitation area, which does not exist in Greece, and we don't have a clue what does this mean. This is exactly why we say the resuscitation also ananipsy, which is not the proper word. And we try to create it now, and this is created right now as we talk. The last year in Greece, so this crossed out word means was not existing, but now it does exist, resuscitation area. We also need to have the specialties that treat these patients, interventional radiologists, specialists for surgery, and we need our hospitals to be on call 24/7, 365. The helicopter emergency medical services are the way that express this service in Europe. And what they do is they fly to the location of the event, either the trauma or the injury or the head problem or the cardiac problem. They land close to the patient, to the victim, and they take him and go back to the hospital and not to the aerodromio, airport. So the whole business should take place within 30 to 45 minutes, not more than that. And this is what they do in Germany very well. You will see now they have those heli bases. It's something like 80 all over Germany. The radius of each helicopter is covers 60 kilometers. And because the helicopters travel at 250 kilometers per hour, they cover this area within 15 minutes. They take the patient and go back to the hospital of their area. And all this will complete within 35 minutes, 40 minutes, not more than an hour. We do in Greece secondary air transportation from airport to airport in patients that are already stabilized. Primary, like the one that we defined with Germans, we don't have yet, occasionally only. And we do rescue, which means victims that are lost in the sea or in the mountains in a very unfriendly environment. And even if they have a good health, because of the environment will soon be dead. So we need to go fast there. And these kind of missions, we do have them. They call them search and rescue, and we do such missions now. These are the transportations CAV does, the National Health System Transportation Service. Air transportation is 2,200 per year, sea transportation 2,600. Each of those average takes 3 hours. And for each hour of flight, we pay 4,000 euros. And for each hour of ship sailing, 2,000 euros. If you do the calculation, it's a huge amount of money, a lot of million of euros. And this is an example of such a patient, personal example from the area of Ikaria, Rachis Ikaria. It's an island, remote island in the Aegean Sea. This was a motorcycle driver that fell and hit his head. It happened 2023. And we knew personally the people in a cab. We called them. 14:30 was the injury. They initiated the whole process of transportation immediately. The airplane came to Ikaria and took the patient and bring him back to Athens, to the airport. And from the airport came to our hospital. It was just a coincidence. And I know that came to the hospital 6 hours after. This is a very fast transportation for the Greek condition. It's really good times. But again, it's too big delay for a patient that is dying. This guy stayed alive. This is the guy, after 2 days, went home because he was just a minor head injury and not a severe condition. This is the most effective, the power horse we have in the Greek military air services. You see the letters SAR here. They do search and rescue in the sea. The helicopter is called Super Puma. They cover also the secondary transportations. It can transfer something like 18 patients. And they have 700 hours of flying per year for 22 years without one single lethal incident during this service. Before this period, 2003, we have 3 major events. 3 helicopters fell. And after that, 3 helicopters that were for medical transportation. And after that, the Minister of Health, the Prime Minister of Health decided that only the military air force will take this service, and they do it well because you see there is no any more incident after that. Currently, the government is planning 6 bases of helicopters around the Greece in order to cover primary transportation. This is the idea now, to proceed to primary, but still we do it with some steps that need more fine-tuning. We need helicopters smaller and more rapid movement, like if you compare it with the Super Puma. And there is a committee of the ministry that is evaluating various helicopters, various hospitals to develop helipads in the hospital area. And this is taking place right now. You see one of those hospitals, is Hospital Papageorgiou. This is where Mr. Fortune is working. And they do have a helipad. You see it here, you see it here. And this is the entrance of the emergency department. The distance from here to there is exactly 150 meters, 3 times if you move fast with the stretcher. But this helipad is not working well because you see the lights are down. It needs some service. And after that, it will be totally functional. This is this is what it should be the basis of the helicopters around Greece. This tried to simulate the condition we see in Germany, this one, but again, the current concept is to create only 6 of those bases and not 16 that is here. And because we create only 6, there is a problem because everyone that realizes where is the base, let's say the base in Kavala is far away from Alexandroupoli. The mayor of Alexandroupoli wants to bring it closer to him to cover him. So 6 bases is not a good strategy for the future. Maybe we don't have money to do more, but if we want to do long-term strategy, we must decide if more bases, and we start with just 6 of them, and progressively we develop to more. This is more rational plan for the future. More about the health, the national transportation system. 400,000 transportation per year. Major contribution since 1985. And currently we have a gift from a big philanthropist, Stavros Niarchou Foundation, 150 new ambulance cars, 2 helicopters, and 2 airplanes, and 1 more airplane right now before some months in 2025. These guys help with their money to make our system better. This is a study we did back in 2007. It shows that the average time in transportation in Athens, it's 14 minutes, something more than 22 minutes, which is very good if you keep in mind the traffic in Athens. And the workload they do is 28,000 transportations per month. This is a lot of work. The hospitals. Since 2009, we have emergency physicians, a new specialty. We have interventional radiologists since 2012. Currently, 60 of them are trained and working in the hospitals all over Greece, and this specialty is getting better and better. Operating theaters we have all the time, and ICU we have them since 1989. But what we don't have is resuscitation areas. And this is the idea we have about resuscitation area. This plan is coming from the Ministry of Health in 2022, and they designated in this plan that this is a resuscitation area. You see 2 beds, and between them a curtain and a location to wash your hand. And if you approach the patient, you must go on the side of the bed, not directly, but side by side, otherwise you cannot pass. And this is a resuscitation area. This is an area good to die, but not to resuscitate. And this is indicative of the opinion we have back in 2022. And after that, a new hospital came to be built by another philanthropist, Mr. Martinos, and they plan to build a new hospital in the area of Vula. And this is the new resuscitation area as they thought it at the moment. You can see that in order to go there, you need to move among other tables. You need to move among stretchers that are parked there. And after 2 turns, you go in this area where there are 3 beds. The head of the bed are on the wall. You can see it. These 2 beds are in the right angle between them, so you cannot move around them. This is something like a good area for emergency department, but not for resuscitation. It's not effective. And the Ministry of Health suggested some improvement. Finally, the ministry realized what is the proper resuscitation and accepted. And the suggestion is to create in this area just 2 beds, give a lot of space around those 2 beds to move freely, put the head away from the wall in order to go back and do intubation if it's needed. And the access is much easier, not any more trolleys or stretchers or obstacles in the way to go within this area. And the building was built, and before it finished, we went to see what is the progress, and they told us we did the previous plan. But we agreed to do the new plan. What the hell you did the last plan? Well, we didn't understand well. The God is mighty and merciful, and Mr. Martinez, who was present, said, "No worries, I understand the significance. We will rebuild it." He paid $500,000 more. The whole project was delayed 6 months more, but it was created the way it was planned, so it's working now, and it's privilege, we have something to show how things could become in Greece. Another gift from the mighty God. It's called European Union. We didn't have money to create nothing more than that. The philanthropist gave the money to create Vula. But in 2023, this comes from the Minister of Finances. Money come to Greece from European Union, 38 billion euros. The amount of money is big, and you cannot realize how big it is if you don't compare with something that you know. They say that this is the same money we took from Marshall Plan from the United States after the Second War, which was to rebuild the whole Greece after the disaster of the war. A lot of money. 100 of them went for health. In European Union, the average health budget is 6 to 7%. In the United States, I think it's something like 12 or 15. We just took 1%, but that's okay. It's a lot of money to rebuild 127 hospitals, all the hospitals in Greece, and from them 63 rebuild their emergency departments. And in those 63 departments, they create 207 resuscitation beds, like the one that they should do the proper way. And this is a big hospital in Athens, the hospital of CAT. We have a resident from there with us today. And this is the outcome in this hospital. It's finished and it started working now. It have started working. This is the hospital of Attikon, which we visited earlier today. And this is during its construction. And this is during the end. This is tomorrow morning, this morning visit we did there. It's ready and will be given to action within the next week. You see the pedestals and the whole construction. The same will happen to Erythros Hospital, Red Cross Hospital. The same will happen to Nikia Hospital. It's already working. The same is happening to Agia Olga, which has some problems with concrete. So just 2 beds, but properly working all around access to the patients. And the minister create this law that puts in another level the resuscitation areas. Remember, resuscitation, it was 2 small beds in a small area. Now the plan is this, which is proper. And if you want to put more beds, you can expand this area from this way or this way and create more beds. And this is an effort we did in Thessaloniki back in April, where we created a demo of this area so everyone that is interested can come and see and feel how it feels in this area to work. And it went well. One doctor had appointment to come and visit and he didn't came. But the people that fly over realize that its significance. And this is a financial evaluation of the cost of this kind of resuscitation beds to create this area, all inclusive, except of the walls, all the other equipment, the pedestals, the ceiling X-ray machine, and everything else that you need. Cost, if you have just 2 beds, 164,000 euros. If you have 5 beds, the cost due to the magnitude goes less. And this is peanuts. It's something that you can do it in Greece. Maybe it's not good for Harvard or not good for Norway, but for Greece, this is something that will become reality. And this is what is done now, and it's constructed now. And after that, and this is important for our hospital, already in the hospital that they built this issue, they ask what we're going to do with equipment. What equipment do we need? And it's already a ministerial decision on what they need. Everything in detail here, what exactly do they need? And it will be signed and sent to the hospitals in order to take the proper equipment to function those beds. I repeat, the whole equipment costs something like around 100,000 euros per bed. So they need special temperature control because this area needs to be warm. And this should be isolated from the rest of the hospital because if you put 23 degrees in all of the hospital, everybody will walk without dresses. It will be very hot. And you need equipment regarding the airway. and you need ventilators, and you need video laryngoscopes, and you need equipment regarding breathing, like intercostal drains. You need those pedestals that allow you to give oxygen and ventilate your patient without any obstacles coming from the ceiling or from the wall. It's more effective. And you can put the ventilator right here on this bar. You need monitors to monitor the patient, a slave screen, in order to put this with the bed if the patient must mobilize and go somewhere else. You need equipment regarding circulations, like fluid warmer, because every fluid that goes to patients should have a temperature around 36.6, otherwise you make it more cold. And you need a special refrigerator for blood and blood products in the ICU area, in the resuscitation area. And you need this rapid fluid infuser, because otherwise your patient that was exsanguinated and dying cannot take fast enough the fluids that you can give him. And you need chest tube drains that can be used for self transfusion. And the second one is something that I learned yesterday from Juan Carlos. Yes. They are both much less expensive than one we use today in our practice. You need thrombelastogram, and you need a plasma thawer. We were totally clueless about plasma thawer. It costs 4,000 euros. Everybody that we send him these things send it back because he doesn't know what to do with it. It's crucial though to have it. You need bear huggers to warm your patient. You need those specific beds that cost something like 6,000 euros each, that can use it only in the resuscitation area. It has a special mattress that is X-ray transparent. It has the ability to rotate around the floor with these wheels, and it's very convenient with that. You can put the sidebars below the stretcher, the location that patient is lying down, to make more effective the approach to him. You need ceiling X-ray, and you need this whole infrastructure. This is from a small hospital in Johannesburg. And stretchers for their patients, and many, many more details, which is not time to discuss in detail. And also you need something related to children, because children may come there, and you need to have the proper infrastructure to treat a smaller in size human the way you should. Regarding our operating theaters, they're working well, but we don't have the experience for doing proper trauma management. We can do a splenectomy, but more advanced things are not done. Hopefully, Stavros Niarchos Foundation again give a scholarship to train our surgeons in South Africa, and 6 of them went and came back, and they have very good critique on their effort there. And we start building an army that could go and work to the various hospitals that take care of these kind of patients. And this is the Hellenic army that starts interesting on this. They wanted to build also trauma center. This is some pictures from Baragwana that Rian showed you earlier. I thought it was 8 severe cases per week. Just now I realized that this is underestimation. He said 400 cases per week. 400 severe cases per week. A lot of experience. And these are the principles of Americans for the resuscitation area for trauma. They want only 1,200 severe cases. They want 1,200 cases of trauma per year and 240 severe cases above ISS above 15 per year. So this goes for 20 cases per month. South Africa has 400 per month. And what about the system? To put all together, create a system? Well, a law was voted in Greek parliament on the beginning of the year, and the law establishes the principles of the trauma system, the levels and the priorities and the patients that should go there, and I will not spend time on that. The whole thing is overestimated because the system in Greece doesn't have everyday calls. We do calls in the hospital every 4 days, so they put more hospitals to cover this delay in the calls. If we do 24/7 calls in the big hospitals, less trauma centers will be needed. And these are the laws that established from the Ministry of Health regarding trauma within the last 5 years. It's a lot of work and a lot of energy and boost to our effort to create a trauma system. The most important thing is the people. And this is the most important because financially, to build something, you need money once. And then after a few years, after a lot of years, you may have to recreate. But in order to build humans, you need time to train them. And then you must pay them every year, every month, salary for as long as they live. And this is more difficult to be developed. These are the efforts we do with seminars many years now regarding trauma. And these are also some training in the abroad, hands-on in Chris Hannibal Aguanath, Johannesburg is more easy, more difficult in the United States. You need to devote a lot of time to do hands-on, but you can go and realize how the system works, and you can write a paper and you can polish your experience with trauma in a short visit in the United States. You can do Master of Science in these two programs, Emergency Surgery and Trauma. This program accepts new students until beginning of December, and it starts on every February. And this is disaster medicine. And the scholarship of Stavros Niarchos and the Ministry of Health to go to abroad and take the experience we discussed about. The next step should be motivation, and this should come from the Ministry of Health to make this specialty attractive. If you take the few pennies, the low salaries you take as a Greek member of the health system, like a Greek worker of the health system, either doctor or nurses, this is probably not enough motivation to go there, because if you have the option, you go and do a sebaceous cyst at a private hospital and take a lot of more money than doing trauma. So motivation to be professional, good, and education. And before the hospital, we need some changes also to be done. And this is an effort we do with the University of Athens. The paramedics take a degree that it's not good to do something postgraduate. They come to our postgraduate program, and the university refused them because their degree is not equivalent to a degree of the university. So we tried to create a degree in the university, 4-year studies, to create a paramedic from the university, and they could function then as better than what they do today. Additionally, there are 2 laws that allows the nurses to do actions on patients without the order of a doctor. This is major progress, because until 2023, nurses could not touch a patient. Paramedics the same. But now they're allowed to do life-saving procedures like take care of the airway of the patient without the permission of a doctor. In conclusion, the trauma field is energized in Greece after a lot of efforts. We're talking about 30 years of efforts. And the emergency department specialty came on 2019. Major philanthropic organizations support with money. The government realized the significance and create laws that will allow the system to start working. And the European Union gives money to move forward. It seems that the day that you can have a severe injury in Greece and stay alive, it's approaching. These are the members of the committee of the Ministry of Health that work for this project. There are significant personalities all over the world here, Harvard, Switzerland, and this is Prof. Degiannis, which is the icebreaker of the whole thing. He came here after his retirement from South Africa, and he opened the way to move on. He was the head of the committee for many years, and he's really the man that the Vula Hospital became reality because of him. If he was not there, it wouldn't happen. So we owe him a lot. And this is the next step, the future, which is already here. The Vula Hospital is the first that created a proper ICU area, a proper resuscitation area. But the personnel didn't have a clue. What the hell is this? Remember that our idea about the resuscitation area is 2 small beds in a narrow area. So they start pumping their heads around. And we realize how severe was the problem slightly later when we see this picture. Actually, an anesthesiologist working there showed us this picture and make discussion on that. This is the one pedestal, the second pedestal should be one bed here, and this bed should be this way. They put the bed between the 2 pedestals, like it's something like a goalpost and which should stop the ball from passing through. And they couldn't function. More on that. This is a resuscitation trolley. A good idea. A resuscitation trolley is resuscitation, belongs to the resuscitation area. Let's put it on the area. And they find a good way to put it on the area on the blunt spot where the guy that takes care of their way should be. So they cover this area. And etc. So this is a problem because we need to educate them and realize what they should do wrong. And this is our effort on that. Over a period of 10 months, we have funds from Martinos, the one that created the building, is willing to pay for the education now. 8 nurses took the ATCN course related to the emergency and trauma. It's like ATLS for nurses. 4 doctors took the ATLS. 2 more nurses came and did our postgraduate program in emergency surgery and trauma, the Master of Science. And 1 doctor, Dr. Kochaki, the anesthesiologist of the department of Vula, came and did the DSTC, the DATC. And after that, when she went back, the guys immediately put her in charge of this area, explained whatever she understood, and you will see at the end the outcome. But for the moment, this is a picture from the nurses of the Vula that came to do the ATCN. And after that, they start realizing what is the significance of it and ask persistently to get trained on that. And during April, when we bring people from South Africa and America to do this major course in Thessaloniki, they ask. And this little lady here, this is the head trauma nurse of Mill Park Hospital. And they asked her to pass from here. We went to the Vula Hospital and 60 nurses came to hear her talking. This is big number, 60 nurses. And another 100 nurses from the internet were there and hearing. And they were so enthusiastic about what she said that decided on their own. They are not academicians. They are just fighting nurses in the streets, in their work. They decided to translate the protocol that she gave to Greek so they do the work better. And after that, you visit the resuscitation area and see the difference. The stretchers in the right location. The resuscitation trolley left from this area, so it's better functioning. And the top of the whole thing that underlines the progress. We have forgot about that. They went to Temu and buy for $25 this clock. They put it on top of the patient, so they will calculate the time that the patient spends in the ICU area, in the resuscitation area. This is fucking progress. They do it on their own. Nobody told them. They realize. Remember the 88 minutes in the resuscitation area back in Katsaragakis area, 2007. Now we have this. This is a hope for the future. And that's it. Thank you all for your participation from the internet or from close distance. Sincere gratitude for our foreign faculty that came and assisted. Dr. Ioannisi θα μιλήσει αμέσως. This internet meeting is not over yet. We're going to do elections in a while, probably half an hour, and then we'll give to the audience that is care for the Society of Trauma about our work the last 3 years and the financial disclosure of what we have done. And after that, we have elections. For the moment, the educational part is over. We'll probably meet again in half an hour. It's 7:45, so 15, we will open again the Zoom for those that are interested for the elections. Κύριε Γιάννης, παρακαλώ.
Came the road and between the hospital, etc. They are not like German that somewhere around, and it's very difficult to manage from this area. Problematic.
We have a major problem in Greece. One of the facets of this problem is this, what you said. The major problem is the problem we have in our mentality. We need a lot of lobbying to change ideas. You speak about that in big ranked people in decision-making locations, and they tell you, I will give permission for an helicopter to fly over Athens, over this highway. What happens if it fails? You're going to kill me. But this is your responsibility, to take care of your people and the helicopter not to fail. How they do it in London, how they do it everywhere. So we haven't realized that the people are dying. We have 50,000 people that are dying by preventable reasons, and this number should be diminished. And if we realize this, we put priority, we change the gobbles, we change the, they don't allow, you tell the helicopter guys, you must land to this football field. No way, I have permission to land only in a helipad. The whole Europe is doing it everywhere. They land everywhere in the discretion of the pilot. So many things should change. Yeah, mentality and lobbying, and you're in a crucial position to do lobbying. Start speaking about what we miss, and this will change the things in the future. Yes, correct. Yes, correct. Let's make 1 hour. Okay, thank you.